Tell me honestly, have you ever studied oxygen transport from different textbooks for hours and understood every paragraph but still couldn't reproduce answer to this question in your university exam? Meanwhile, one toppers who write just like this 4 to 5 pages, draw one simple oxygen dissociation curve, use proper headings and easily score 9 or even 10 marks. What is the difference? It's not the intelligence, it's the presentation skills. In today's video, I will show you exactly how the toppers write oxygen transport in physiology exam. By the end of this video, you will know the exact answer structure, the important diagrams, the examiner's favorite flowchart, and one graph that fetch you marks almost every year. So let's begin. So let's start this long essay question with a definition and principle. Oxygen transport. It mainly occurs due to constant circulation and diffusion, but strictly driven by the concentration gradient. Let's understand this with a physiological story. Oxygen. It begins its journey from the atmosphere. It enters the alveoli, then diffuses across the respiratory membrane into the pulmonary capillaries, travels in the arterial blood and reaches the tissue, and finally enters the cell where it is used for its metabolism. This simple flowchart immediately tells the examiner that you understand the concept. If you draw this oxygen journey neatly, your answer instantly look more organized. So let's understand gradient summary. Gradient. So the pressure difference between lungs and blood is about 64 mm of mercury, whereas between blood and tissue it is about 55 mm of mercury. But once the oxygen enters the blood, how is it actually transported? That's the examiner next favorite question. Of the important highest yield slide, forms of oxygen transport in blood. Remember just two numbers. 98.5% of oxygen is carried in combination with the hemoglobin, whereas 1.5% of oxygen is carried in dissolved form. Students often memorize these values but forget the importance. Why we need hemoglobin? Because the dissolved oxygen is only 0.3 ml per 100 ml of blood, and this much of oxygen can never meet the body's oxygen demand. Imagine transporting hundreds of students by using a single bicycle versus a large bus. Hemoglobin is that bus. Hemoglobin transport about 19.5 ml of oxygen per 100 ml of blood. And this process is oxygenation and not oxidation. Remember, 98.5 hemoglobin, 1.5 dissolved form. Always write this percentage in your answer. Examine notice the accurate figures. Let's understand oxygenation kinetics and binding. One hemoglobin has 4 heme molecules and one heme binds with one oxygen molecule. So one hemoglobin molecule can carry about 4 oxygen molecules. Now instead of memorizing chemistry, remember this visual. One chair, 4 seats. So each seat is occupied by one oxygen molecule. This binding of oxygen with the hemoglobin is called as cooperative binding. What is it? Progressive binding of oxygen with the hemoglobin changes its state from tense state to the relaxed state, and this is responsible for the sigmoid shape curve. Remember, the cooperative binding of oxygen with the hemoglobin is the reason for the sigmoid shape oxygen hemoglobin dissociation curve. This graph alone fetch several marks. Oxygen hemoglobin dissociation curve. Let's start with the definition. So it is a plot of PO2 versus saturation of hemoglobin. The shape is about sigmoid shape due to the cooperative binding kinetics. Now this graph shows two distinct zones. Loading zone, which occurs at the lung level, and unloading zone, which occurs at the tissue level. Loading zone, it provides a margin of safety. That is, hemoglobin remains 90% saturated even if the alveolar PO2 drops to 60 mm of mercury, whereas unloading zone, which occurs at tissue level, at this, the small drop of PO2 releases large amount of oxygen. Remember, there are two zones. Loading zone at the lung level shows safety margin, whereas unloading zone at the tissue level shows tissue buffer. Always label this loading zone and unloading zone in your graph. Let's understand right shift of oxygen hemoglobin dissociation curve. Imagine a person is running. In this case, there is increase in PCO2, increase in lactic acid accumulation causes increase in H plus ions, increase in 2,3-DPG, and elevation in temperature. Now all these signals tell the hemoglobin to release more oxygen, that is decrease affinity of hemoglobin for oxygen, and this causes right shift of oxygen hemoglobin dissociation curve. You can remember this by mnemonic, that is cadet phase right. Cadet, C for carbon dioxide, A for acid, D for 2,3-DPG, and ET for elevation in temperature. Remember, and this causes Bohr's effect, that is, increased carbon dioxide in tissue forces hemoglobin to release more oxygen. The physiological impact of this is tissue get significantly more oxygen during exercise. The opposite situation gives left shift, that is, increased affinity of hemoglobin for oxygen, and this occurs in decreased pCO2, decreased H plus ions, decreased temperature, and decreased 2,3-DPG. Here, the hemoglobin holds the oxygen very tightly. Now let's understand one more important question for Viva, that is concept of P50. What is P50? So it is the partial pressure of oxygen at which hemoglobin is 50% saturated with oxygen. Normal value is about 25 to 27 millimeter of mercury. Remember, P50 is inversely proportional to the hemoglobin affinity. So decreased P50 causes higher affinity, left shift, and increased P50 causes lower affinity, right shift. Fetal hemoglobin dynamics. This is the beautiful physiological adaptation. The fetus cannot breathe on its own. So fetal hemoglobin must steal oxygen from maternal blood. But how? By having higher affinity for oxygen. That's why the fetal hemoglobin shows left-shifted dissociation curve. The structural reason responsible for this is fetal hemoglobin has 2 gamma chains instead of 2 beta chains, and this is having very low affinity for 2,3-DPG. But what is the physiological importance for this? At a placental pH of 20 mm of mercury, where adult hemoglobin is only 35% saturated, the fetal hemoglobin is 70% saturated. That is, it stores effectively double the amount of oxygen. Now let's revise two clinically important curves. First one is carbon monoxide toxicity. Carbon monoxide having 200 times greater affinity for hemoglobin than oxygen. So oxygen cannot bind with hemoglobin. Rather, carbon monoxide bind with hemoglobin forms carboxyhemoglobin, and this causes shift of dissociation curve to left. Second curve is a myoglobin, that is hemoglobin present in a skeletal and cardiac muscle. This dissociation curve is a rectangular hyperbola because it has only one oxygen binding site, and this does not show the Bohr's effect. At resting PO2, where hemoglobin is 75% saturated, myoglobin is 95% saturated, so it acts as a temporary storehouse for oxygen during the sustained muscle contraction. Transport isn't enough. This oxygen must finally reach the tissues, and this amount delivered depends upon two factors: arterial content of oxygen and the cardiac output. If either of them decreases, the whole oxygen delivery decreases. Now the oxygen consumption at rest. At PO2 of 40, blood releases about 5 ml of oxygen per 100 ml. So that gives oxygen consumption 250 ml per minute. Now the oxygen utilization coefficient, it is about 25% at rest, whereas during exercise it increases to 15 to 16 ml of oxygen per 100 ml. Now let's cover the last part of the question, that is a Bohr's effect. Here there is an entire curve shift to the right side. There is a new pink line. As you can see, there is decreased affinity between oxygen and hemoglobin. But what are the causes to this right shift? Remember cadet, that is increase in carbon dioxide, increase in acid, that is H plus ions, increase in 2,3-DPG, and elevation of the temperature causes this right shift. Let's understand this unloading calculation of this Bohr's effect. On this new pink curve, saturation drops from 75 to 60, about 38% more oxygen is unloaded. As compared to the normal, where 23% is unloaded, the right shift forces 15% more oxygen into the tissue at the same exact pressure. Congratulations, finally we have completed the answer to this long essay question on oxygen transport in the blood, oxygen dissociation curve, and a note on Bohr's effect. We have completed the answer under the following headings, that is the definition and principle. We have drawn this flow chart showing the oxygen pathway, then the oxygen transport in the blood in the form of two waves, that is dissolved form 1.5% in combination with the hemoglobin 98.5%. Then we have seen this oxygenation kinetics and bonding, the cooperative binding between oxygen and hemoglobin, which is responsible for this sigmoid shaped curve, and the most famous oxygen hemoglobin dissociation curve showing two zones, loading zone and unloading zone. We have also seen this right and left shift of this oxygen hemoglobin dissociation curve, a small account of the fetal hemoglobin, and the spatial dissociation curves in the form of carbon monoxide and myoglobin, that is the skeletal and heart muscles. Do not forget to draw this important diagram of oxygen hemoglobin dissociation curve showing loading zone and unloading zone. This flow chart, this shift of these zones, and very important, the Bohr's effect explanation with the help of note and a diagram together. If this video helped you understand how to write a perfect university answer, give it a like and share it with your batchmates. Watch a 5 minutes rapid revision video if your exam is near, or watch a memory trick video to remember the oxygen dissociation curve and related concept without rote learning. See you in the next Physio with Neo video. Thank you.